Is Tamer here? Tamer, shall we start? Okay. Good afternoon, ladies and gentlemen. So first of all, welcome to this cataract section which we are going to have, and we have panelists Jorge Alio, Tjia, Safwan, Mohamed Hesham Ali, and Ramon Misa. Now the first thing which we thought, as you realize here, is how do you manage a compromised corneal endothelium in cataract surgery? The reality here is, today corneas are getting damaged. This is the reality. This could be one because we are at fault in our surgery somewhere. It could be that previously we were missing the fuchs, and today there are complications because more surgeons are being operating more patients. So there is an issue definitely of bad corneas and cataract surgery. And this, I think, is an excellent session Tamer and the whole Maghrabi group have started. So let's have, first of all, an audience response question. How do you manage a compromised corneal endothelium in cataract surgery? Can I have does it come up on the screen? Lovely. Now, question here is, do you do the cataract surgery first, then manage the cornea if the patient is complaining? Alternatively, do a keratoplasty first, then have the cataract surgery as a second step. Simultaneously keratoplasty with cataract surgery. So let's see the audience, what are you voting for? Have you got your voting pads, I hope, everyone? Is that working? Or does it show only 6 people have voted? Cataract surgery first, then manage cornea if patient is complaining. That's going neck to neck. Simultaneous keratoplasty with cataract surgery. So you see, it's still 50-50. One is really not sure what the situation is like. So I think that's one of the reasons why we have such an important session. So let's have the first speaker who's going to talk to us on combined cataract and keratoplasty surgeries, Jorge Alio. Before I bring up and ask Jorge to talk, one person who introduced me to ISRS was Jorge Alio. I don't think you will find people who have a combination of surgical skill. He can sit on a table with 100 ophthalmologists and talk to them on surgery. He can sit on a table and talk to them on clinical. And believe me, you can sit on a table and talk to 100 venture capitalists also. That's very tough.
Oh, thank you very much.
You know, to talk to private equity players and with balance sheets which at least people like me don't understand. Jorge will perhaps read it like the back of his hand. Jorge, all yours.
Well, thank you very much, Amar, for the words and your friendship, and it's a honor and a pleasure to have you present in this session, because we have a lot of discussion. Probably you will have a lot of solutions to our problems, and the topic is a very relevant one because we frequently have problems with cornea, and we need to perform cataract surgery. The first thing is to make indeed a point what a challenge it is, because we have in these cases not only that the corneal influences the outcome of cataract surgery, but definitely cataract surgery can be an opportunity to correct many problems in the cornea. So how to match and how to fit the cataract in the corneal problem and the corneal problem in the cataract is the art of being a surgeon. And indeed we have three main issues. The visual outcome, which has to be acknowledged, that has the cataract the potential, if surgery is performed, to improve the vision of the patient, because we have other reasons to limit the vision, which are the corneal ones. The refractive outcome is indeed an opportunity for the cataract surgery, because we can, with modern lenses, to correct up to more than 15 diopters of astigmatism, if in cases that we have this problem and are adequate for the purpose. And indeed we have risk factors that is specific for different places, for different groups. We don't have only group of patients, we have different group of patients depending on risk factors, and these are the 4 groups of patients that I have in my own opinion. We have patients with limited endothelium and a risk for corneal decompensation that come for cataract surgery. We have cases with previous corneal graft that have cataract and need surgery. cases with previous corneal trauma that have scars, problems, and irregular astigmatism, and definitely needs cataract surgery. And we have cases with previous corneal refractive surgery, which are very complex. I will focus mainly in the first and second group because the others are not in the time of this presentation. The question that the surgeons have, and your concerns, and my concerns are, number one, how to select the best surgical option. Is combined procedure only cataract, or should we go for the cornea first? Second, how to calculate the power and the toricity of the lens, and that is different depending on the decision that you make in the first question I offer to you. The third is that you need to planify the surgery. They are not different in normal cases. You need to planify, and in my hands, and I'm sure that Amar already makes this opinion as well, we need micro-incisional cataract surgery procedures in order to minimize the trauma to the cornea and to control the refractive outcome. The aim of the surgery is the preservation of corneal integrity, to have a successful anatomical and visual outcome, and finally to have a good refractive outcome, because we are refractive surgeons. This session is an ISR session. We target refraction, not only vision, we target both. And these are the clinical examinations that I consider that are essential in order to make a decision. All of them are available for you. Of course, I want to make a point about the visual acuity with contact lens and potential visual acuity with a rigid contact lens. Sometimes the cataract is irrelevant, and what you have is an irregular astigmatism problem. And indeed, you have the other examinations just to know how is the refraction to be attended. Making a decision, you have to have an interview with the patient. We shall go through this immediately, which is the clinical aspect of the cataract, because the density and the appearance doesn't correlate well, as you know, with vision. The corneal topography and barometer are mandatory in order to make a decision whether the cornea is involved or not in the bad vision of the patient. Corneal pachymetry, if the endothelium is diseased, is as important as the corneal, as the endothelial cell count, and the potential visual acuity estimation is something that I indicate at this moment extremely careful to be performed before the surgery, and obviously you need to consider other comorbidities, and the main one is glaucoma. If you have a barometer like this, doesn't matter the cataract surgery you are going to do, the patient will not have good vision. But you have barometers like this with less than 2 microns of hydro aberrations, you have to have a guarantee of a successful outcome. So how to know and how to grade the cornea in terms of what is the performance of the vision depending on that corneal irregularity. Nobody knows, but I will tell you how I do it. We published this paper 2 to 3 years ago about how to measure corneal irregularity by high-order aberrations. And we did this because we were looking for a different classification of keratoconus. I will talk to you in this very session at the end about this again. And we reached to the conclusion that the degradation of vision is parallel to these factors. As I told you, I will tell you about this, the way in which we estimated this. But if you know how is the keratometry, how is the internal astigmatism, which is the difference between the refractive astigmatism and the astigmatism of the anterior corneal surface, how many microns of higher order aberrations you have, and which is the sphericity. But basically with these 2 parameters, you know that the vision will be between 0.9, 0.6, 0.6, 0.4, etc. So this classification of keratoconus based on vision will tell you about how is the corneal regularity related to the vision that the patient should expect after the surgery. Very important concept that I want to share with you. And we have pachymetry. And indeed, what I prefer, the OCT tomography, because it's not the same to measure the cornea here than there. Here is more than 900 microns. When you have more than 900 microns, you are talking about that decompensated cornea that will not tolerate any type of cataract surgery, and not only that, will not be with good vision. So the retinal acuimeter and the macular function test are 2 examinations that either of them advise you to do. With them, you estimate which is the potential for vision of the whole diopter of the eye. Not only about the cataract, but about the whole problem of the eye. And this is important if you have comorbidities, particularly at the macula. And this is the macular function test, probably the easiest one. This is a picture of Jerome Briggen, my friend from Belgium, that indeed created this very simple test. And this is the most sophisticated, that indeed is very useful, the retinal acuimeter, that indeed is easy to attend and to understand by any person, and provides to you about how is the visual potential of the patient if comorbidities exist. If you have a disease endothelial cell loss obviously is measured at the center, but you might have a reserve in the periphery that is enough. What tells you about the disease endothelium will tolerate or not cataract surgery is how is the visual fluctuation along the day, and you need to talk to the patient. And talking to the patient, you know if the patient has no fluctuations, moderate or severe. If they have severe fluctuation, you need to know that endothelial cell count with less than 300 and severe fluctuation are corneal decompensation. But you have central cornea thickness of 700 to 800, and especially more than 800, with any of the two other conditions, you are with a cornea that is not going to be good for any other than combined cataract and corneal surgery. This is indeed one important issue, and the other one is to protect the cornea. The only one product that really protects the cornea on a long-standing basis is the viscoat, because chondroitin sulfate, as you know, adheres to the corneal endothelium, and you replace it several times in the surgery. You preserve this disease endothelium indeed much more. You need a special informed consent not to be protected about unexpected problems, and especially about unexpected expectations of the patient of the surgery, and you need to use minimally invasive cataract surgery. This is the book that we published with Howard Fine 4 years ago. Minimizing the incision, you maximize the outcomes of cataract surgery because you are less invasive, you are much more conservative, and you preserve also the integrity of the cornea. So, what to do with a combined cataract and femtosecond cornea graft? I use femtosecond in all my grafts because reasons that I will tell you later in the day. But the issue is that precision that we have, we can perform the pre-cut cornea and to perform cataract surgery safely. You don't enter the eye. And not entering the eye, you are in the adequate depth. You are doing the job that you want to do, and you don't need to do cataract surgery open sky, because this is dangerous, usually finish with a visual loss, with a vitreous loss, and indeed is not adequate. I have cleaned the epithelium, and now I am and what I didn't clean before because our cornea thickness is measured with the epithelium. Now I remove, and look, you can see that in these cases I usually use vision blue because sometimes the glare and the scattering of light is not good for the capsulorhexis. But if you use this, you can do cataract surgery with a pre-cut cornea in that totally stable condition. We use the zigzag procedure, and then we follow the normal cataract surgery. In this case, a hard cataract is performed, pre-chopping is being done, and I follow with 2 1mm incisions, as Amar does for many, many years, and indeed we finish in the right way in this case. What happened with previous corneal graft surgery, you have special cases as well. It's a unique opportunity to correct astigmatism, and I do it only if the patient has at least 1 year follow-up of the corneal surgery. The main challenges are corneal astigmatism that only is known when you remove all the stitches. Endothelial dysfunction is frequently present because we have elderly donors, and the surgical manipulation makes the endothelial cell to be affected, and poor cell count is usually frequent in these cases. You need to remember the risk of immune reaction is multiplied by 4 following cataract surgery. So you need to protect these patients with the adequate immune suppression or with topical steroids, and you need to be sure that the stability of the corneal scar is never known. So even in long-standing cases, sometimes you have a case that you have an unstable corneal wound, you need to look to work with low fluidics in these cases. There's a case in which you will see is still with the sutures because this patient had almost no astigmatism. So we decided not to remove the stitches. It probably is wrong, but this is what we decided. We do 1mm incisions. I use mydriatics only intraocularly. I don't use topical mydriatics since many years because I control the mydriatics in a much better way. I do pre-chopping. Doing pre-chopping, you decrease two-thirds of the effective focal time and total ultrasound power, and I follow with the bimanual microincisional cataract surgery, as you know that we are doing for many, many years. So with deep anterior laminar keratoplasty, things are easy because if you use the femtosecond, as we do here, you are going to be in the depth that you want. So you remove the keratoconus or the opacity or whatever is the pathology to an adequate layer from which you have a transparent cornea, and with this transparent cornea you perform normal cataract surgery. You can use methylcellulose, which in the short refraction increases the visibility in the anterior chamber, and thus allows you to make a good use of the vision blue. And then once that the vision blue is evacuated, you can do a good capsulorhexis and to follow with any type of bimanual or monomanual procedure that you want. In this case, we're going to be coaxial because we didn't have in-depth facility the machine that we use, which is the Stellaris. You see here that we do a normal capsulorhexis. Usually it's about 5 millimeters, but we have a complete transparent cornea or almost transparent that that is very much welcome to have the visibility that offers to you the Vision Blue in order to make a much better cancerosis. Pre-chopping is performed. As you see, this is a hard cutter as well, and with this you decrease the aggressiveness of the procedure as well. Endothelial keratoplasty is, in spite of what is thought, tolerates well cataract surgery. So if you are careful, you don't use high volume fluidics, you can do in this case cataract surgery normally. My advice is to decrease the fluidic rate and to do the cataract surgery with the normal technique. And in conclusion, we have in this particular group of patients, which is very special, to be aware of the condition that you are treating, to make a comprehensive clinical examination, to design your cataract surgery adequately for the purpose, to use toric IOLs if you have 2 or more diopters of astigmatism, to pay particular attention to corneal endothelium and to protect this in any case, and to use a specific free informed consent because you face risk that you don't know and the patient should share with you this outcome. And I thank you very much for your kind attention.
Thank you very much, Jorge. I think that was a very nice covering of the topic which you had. Now let's look at other topics like the PDEC technique which I talked to you about. Can I ask the audiovisual people, can you put the third video first? If you see there was 1, 2, 3 videos, put the third video first. Now,
financial interest in the products or procedures
can you
shown.
off the audio, please? No audio. Yeah, just play the video. Let's look at this video, and what I thought I'll show you is another way of endothelial keratoplasty, and I talked a little bit in the morning for you, but let's look at this now here. Now when you see a patient, can you play? Yeah. This patient has got, if you notice, a Fuchs dystrophy, and the question is how do we manage these patients? And you can see the cornea is quite hazy. I've taken off the epithelium there. Now remember again, I'm taking this 30 gauge needle, and you know you have to give credit to Anwar. Is Anwar here? Anwar, I don't know enough words to thank you in life for creating the dark big bubble, but we are doing this upside down. To be honest to you, this is just Anwar's bubble, but it's upside down, which he was doing from the front, and you can see I've created a bubble there. Once I've got the type 1 bubble, how do you know this is a type 1 bubble? The type 1 bubble does not go to the periphery. This means the space is between the predesmase and the stroma. If it went to the periphery, that is a type 2 bubble that is between the predesmase layer and the desmase layer. So that you can create a DMEC graft. Here I'm creating a PDEC graft, predesmase endothelial keratoplasty. Again, to repeat, biggest advantage, I can do this in any age donor eye. DMEC cannot be done. You need a 40, 50-year-old donor. DSEC, it's too thick. So you will have another problem when you take an infant cornea, you'll get rejections. So coming back to the patient, you can see I've taken off the epithelium now to get better clarity. Cataract is there. Now at the same time, you just finish off the cataract, any technique of your choice. Once you have finished off the rhexis portion, you might go ahead, do your hydrodissection, do your phacoemulsification. Again, technique of your choice. Here the advantage here is, anyway I'm removing off the endothelium. So it's not going to make any big difference by damaging the endothelium more, because I know I'm anyway going in for a PDEC procedure and I'm going to complete that anyway. So here you can see removing of the cataract. Once my cataract comes off, then I will go in for my IA, and you can see there I'm finishing of the irrigation aspiration. If you notice, the amount of fluid coming into the eye is a lot. Remember, and I think Tjia will be talking more on the fluidics here. This is the air pump system which we use in all our cases here. It's a simple aquarium air pump which pumps air into the bottle, but the amount of fluid which you get into the eye is so much. Now once you have removed that cortex, etc., just implant a lens of your choice. So you can see now I'm injecting it, and while injecting you notice that the endothelium was so bad, it has already come off, portion of it is already stripped off. So you can see there, portion of the endothelium was so bad, so I might as well just, since it had come off easily by itself, saves me the headache to remove it later, put a lens of your choice. Now, once you have got this lens implanted, the next game is very simple. Fix an AC maintainer. I always fix an AC maintainer because if I'm using it to strip my endothelium, you can use strip-on glue to check if you're missing anything. Once you have removed the endothelium, take your graft, put it into that injector and inject it inside. You see, in this case, I don't have any other complication. It's a simple, pure cataract surgery. So life is a bit easier compared to the one which I showed you in the morning session. Here you can see I'm unrolling the graft. Once my graft gets unrolled, I will go under the graft, above the IUL, inject the air and fix my graft back into place. And now you can see with the endo-illuminator assisted PDAC, as I told you again, you see I'm using an endo-illuminator to help assess where I am. And once I have done that, you will see I'm able to then fix my graft very well. In DMEC, the problem which I face is it will just tear off if you manipulate a little bit even. Once that's done, this is how the patient looks at the end of surgery. And you'll see there the graft fixed, and same patient you can see post-op 1 month, patient improved very well to 20/30 vision. And this is how the patient looks 1 month post-op. You can see the slit lamp photograph of this same patient, and same patient 6 months post-op. You don't even realize this patient had a PDAC surgery. You can see the pre and the post and the anterior segment OCT below. Can I play the first video now? Now let's take this difficulty slightly more, and then we will see what we can do and how to take this game to the next level. Now, in this particular case, which we should show you here, is this. This patient was a patient who was operated elsewhere, but the key issue here is this is the youngest donor PDAC graft I've used, or anyone used in the world right now, because this is a 9-month-old donor. So you can see now with a 30 gauge needle, I'm creating this type 1 bubble. Again, as I'm repeating it for you here, look at that bubble, it has not gone to the periphery. Now, when you take these infant donors, it is stuck firmly, so it's easier to create a type 1 bubble. If you go older, take a 60, 70-year-old patient, and you go for this bubble, you might by mistake create a type 2 bubble, which is not your fault, frankly, because it is partly a blind procedure, and because the desmase is loosely attached to the pre-desmase layer or the Duas layer, that type 2 bubble can start forming. Now look at that patient's scarring. That's what I need you to see. See the white scarring. I'm taking off the epithelium. Still you can see it's quite bad. So anyway, the patient has an IUL which is subluxated. I'm creating my 2 scleral flaps. Once I have made my scleral flaps, you'll see there, I've dissected the 2 scleral flaps because obviously this patient will go in for a gluteal surgery, definitely. So here you can see the first flap made, my second flap made. Once my 2 flaps are made, I will go ahead always with fluid in an eye. Never use viscoelastics in these cases because you don't want the viscoelastic going down, because obviously the posterior capsule is not present there. Now I'm going to explant this IUL because 1, I'm not confident of that IUL inside. 2, I can't see clearly what's going on inside, so I might as well take it off. So I'm making a scleral tunnel. I fix my trocar cannula in this case. Remove that IUL, and you can see it's quite badly deformed a bit. Go ahead, do a vitrectomy. Now the advantage in glued IUL in such cases when you're operating is, even with such media, notice, it doesn't take me much time to do the glued IUL because the process is very simple. You're using the glued IUL forceps, and you can see once both haptics are externalized, I'll create with this 26 gauge needle the Gabor-Charius tunnel. I think Dr. Tjia will be talking tomorrow. Tamer has asked her to talk more on glued IUL, so she'll cover it up tomorrow in the session in the morning. But now again, pupil is badly deformed. So I'm trying to do as much as I can. But let's be real, it's not going to happen too much, but as long as I can get enough pupil bang on track so that my air remains on track. And now you can see here, I'm taking off that endothelium. Once everything has come off there, now I take the PDAC graft, which I kept in the MK medium. There you can see I'm just putting the MK medium there, loading the graft onto a simple MIS injector, any injector of your choice, and any IOL injector which you have, you can use for this. there are various ways to know how to inject these grafts, which you all know perhaps. And once I have injected it inside, I will then unroll this graft. So you can see there, look at the media again. I can't see which side is right and which side is wrong. There's no way I can do that. But once you start using the endo-illuminator, you'll start realizing you'll be able to catch which side is right and which side is wrong. I'm injecting the air, fixing the graft back. Once my graft is attached, and notice my AC maintainer is on now, continuously infusing air inside, fixed with fibrin glue. That's how the patient looks at the end of surgery, post-op day 1. And you can see pre-op and post-op day 1. The anterior segment OCT is below. And now, let's see something more in this case. What we need to see here is, this is post-op day 4. Look at the epithelium, it's growing back. 1 month post-op. Look at the scarring which I wanted to show you here. 45 days post-op. That's the anterior segment OCT. And let's recap on that, and we will realize what I'm coming to. My point here is this, that as these cases, you can see how the patient was pseudophakic bullous keratopathy pre-operatively. This is without epithelium, and now you can see how this patient has improved to 45 days post-op. This is a 3-month post-op picture, and the question is, you can see that scarring has become nearly gone, pre-op, post-op, and my latest picture I have is a 6 months post-op. It has improved much better. Can I have the last video, please? The last clipping which I thought I will show you is, I showed you one with phaco done, one with the subluxated IUL done, and the last clipping which I thought I'll show you is another lady who had come to me. She was, I think, about 55, 60 years of age. And when I saw her, she came to me like this, pre-desmis endothelial keratoplasty to be done on her. But look at that, there was a bad endothelium, obviously. This steps you know. This was a 24-year-old donor eye in which I created this bubble. And I tell you what, I love operating when I'm able to get a patient with a young donor. It is difficult, but the question is, I think the eye banks globally are not understanding the importance of doing with such young donors, let's say an infant donor or something, because obviously a penetrating keratoplasty would fail in these patients. Now once I have got it, and you can see the bubble is quite good in this particular case which I have created here. Simple process is, once you have got this thing, is enter with a knife. See, I'm entering into the knife and puncturing the bubble. Once I have punctured it a little bit, I get an opening and I just inject trypan blue inside it. Now what this trypan blue does is, one is it delineates the bubble, two is it will stain my bubble very nicely inside. So once I have done that, I just take a scissor and cut. Don't try to peel it off, please, it will never peel off, because the pre-desmis layer gives a splinting to the tissue. And you can see there, once that graft has come out. Now why I wanted to show you this case is, look at again the scarring in the center. A little bit of scarring is there, perhaps not that bad as the previous case which I showed you. Take off that epithelium, but this is a comparatively easier case. So I'm here just going to inject my air inside with the air pump on, take off this endothelium, and you can see now I'll just take off this endothelium. So when I'm taking off my endothelium, my chamber does not collapse, because I've got all the time air continuously infusing inside with the air pump. So once my endothelium has come off, I will now take my graft, load it inside, and I will just inject it inside. Here you can see I'm using both hands, right hand and left hand, the reverse Sinski system of creating this desmetorexis, and you can see they're trying to remove it en bloc. Suppose you have left a tag behind, just stain it with trypan blue. You will see where the tag has been left behind, and you can always go in and remove it. But don't leave a small tag behind also. Take the graft in the injector just like I showed you just now. Once you have done that, load it, inject it inside, and then we are bang on track. Let's see how it looks at the end of surgery here. Here you can see now I'm just loading it. I might sometimes make the pupil myotic if it is not. In this case it's pretty small, so it's good for me. Unroll the graft. Once you are inside, just put some suture. Use the endo-illuminator as I told you about the EP deck. Unroll the graft here as you can see. Inject the air and fix this graft inside in place. Now let's see how this patient also did at the end of surgery, because it's important for us to realize that. And you can see once my graft is fully unrolled here from outside itself, I will go inside and I'll inject the air. So I'm going carefully with my cannula just under the graft above the IOL. Once I go to the center, I inject. And you can see the graft nearly attached there. At that stage, now you can put in a AC maintainer so that your bubble is nice and taut there. And once you do that, check with the endometer that every portion is fully attached, because you don't want some rolls or some folds in that tissue there. Now let's see how this patient did at the end of surgery. And you can see 1 week post-op, 20/40, this patient did. 3 weeks post-op, how this patient is looking. It's improving, as you can see, gradually. And look at this picture, 3 months post-op, she improved to 20/20. Thank you very much, ladies and gentlemen. We have now with us the next person whom I'm going to call on stage, ladies and gentlemen. And he is another very dear friend of mine, and that is Tjia. And he's going to talk to us on phaco machine fluidics. Now, before I ask Tjia to talk, let me tell you something about him is, I had the pleasure to spend a lot of time with him recently in Cairo with Francisco Carones also. And you would not find someone with such surgical skills, and not only the surgical skills he has, but the lovable heart which he had. And I had a lot of time spending and bonding with Tjia. And the surgical skill, the subject matter which he brings on table is something phenomenal. And I think there's no one better, because fluidics is something which, to be honest, is very confusing to each one of us. Tjia, over to you to talk to us on the phaco machine fluidics.
Thank you so much, Amar, for your always very kind words. Brand new clinic, retro style. It's very recent. Moved in there a couple of months ago. Could not withhold you from this beauty. How modern fluidics can benefit cataract surgery, and in particular, the compromised eye, as we discussed now. Until recently, virtually all, not all, but most widely used phaco machines were dependent on gravity-fed infusion with bottles hanging on a pole. And that results in infusion pressures which vary greatly. Just an example, when you have an infusion pole at 110 centimeters bottle height, on full occlusion, the intraocular pressure will rise to 80 millimeters of mercury. And during the surgery, and on occlusion break, that intraocular pressure will drop very significantly. And if you have significant surge, that intraocular pressure can even drop below zero. That's when you get scared and the posterior capsule pops up. So basically it varies, and it goes up and down immensely. So the new machine which Alkan introduced 1.5 years ago has dealt with this issue completely. I'm not going to describe that in detail. I think you have seen that a couple of times. May I ask who of the audience has access to this Centurion machine? Oh, not yet too many, so there's opportunity for people to buy one. I am a consultant to Alcon, by the way. But basically the whole system is not air infusion, it's not gas pressurized, there are just mechanical plates which are extremely responsive, and thereby enabling the surgeon to set a certain target IOP which is really maintained during the entire surgery. Complete novel idea, and it really works. So you have a stable intraocular pressure which is of your choice. So mine is 36. There are surgeons who prefer slightly higher intraocular pressures, and some even prefer lower. But what they all share is that the anterior chamber stability is unsurpassed until present date by any platform. And why is that? So on one side there is the infusion with the active pressurization, and which is carefully monitored by those two sensors on the bottom of the cassette. But also on the bottom left you see a cross-section of the tubing. And the tubing in combination with the cassette design are such that the amount of contraction of that tubing is significantly reduced. It's reduced by half. And the contraction of the tubing causes the occlusion brake surge. So this is a graph of that occlusion brake surge comparing the old Infinity FMS, the deep trough. So the deeper the trough and the longer the trough, the more fluid is drawn from your anterior chamber on occlusion brake moment in time. And then the enhanced Intrepid FMS is the middle one, and a very significantly reduced occlusion brake surge of Centurion. And it is a fact. That is not just marketing. It is something you really... so there's one of our colleagues. There's a big proof because last year I gave the same talk here in Abu Dhabi, more or less. And so you bought one and you testify. He's not, you're not a consultant, are you?
Yeah.
You're not?
Sorry?
You're not a consultant to Alcon?
No.
No, so he's not paid. I'm paid. But, so.
Unfortunately not. And I'm not paid.
So just to remind you what occlusion brake surge with a second generation, so we're now fourth generation. This is a second generation machine of unknown making, but I know which one it is, but I don't want to tell you. So this is occlusion brake surge as it can be. There was already some air aspirated. So this is pretty extreme, but just, you know, to shake you up a little, so what can happen. Nothing happens here. So this is my own video, so I'm not going to show disasters all the time. But just to show you the variation in intraocular pressure of the old Infinity cassette, not the Intrepid. So nothing happens, the surgery is fine, but you see the variation in intraocular pressure by the iris moving a little bit and a trampolining. Actually, this is what you see to a lesser extent in most of your machines, but you're used to it. You recognize, but you know, if nothing really happens, no posterior capsule break occurs, you're fine with this. You see the constant intraocular pressure variation. And then, with Centurion, look at the anterior chamber stability. It's pretty boring. It's an absolute boring video. Why? Because it's so freaking stable. And look at the vacuum settings. They're 500 plus. I don't work even with 500 plus, but just to show you how stable it is.
The last step that we're all scared of.
Yes. So the last quadrant.
Create a lot of damage to the capsule.
So I get a lot of support here. So we feel much more secure.
Yeah.
Definitely. And this is the same thing. There's a vacuum setting of 550. Actually, I use around 500, 475 nowadays, which is largely enough. And that even increases your margin of safety if you aspirate a little bit of air, which increases the occlusion brake surge. something happened to the video.
Can you tell us something about the bottle height?
So the question is, can I say something about bottle height? So this is working with target intraocular pressure. There's no, so you just indirectly measure the intraocular pressure, and you set a certain desired target IOP. In my case, it was 40 millimeters of mercury. I now set 36, and that is within a certain range maintained during the entire surgery. So in relation to bottle height, 40 is in the range of 60, some,
60-75, that's according to the...
60, yeah, 40 is quite a bit. 55 is 75 centimeters bottle height. But big differences, it goes up and down all the time with the gravity fed. Here it is almost constant. So it is really convincing, it is really significantly better. But I do want to point you at, or what convinced you last year, that torsional ultrasound in 2006, and I was very heavily involved in the development of this technology, was designed but introduced with phaco tips which were used for longitudinal ultrasound. And in 2006 I kept on insisting developing a new phaco tip, the balance tip, which eliminates the movement at the shaft. So on the right-hand side, you see the Kalman tip, and on the upper graph, you see the movement at the point of the incision. And on the bottom graph, you see a thermal picture indicating that due to friction, there is some heat production causing low percentage stromal changes, also called mini wound burn, which is eliminated. I mean really eliminated with balance tip, because there is no significant movement left. And here you see the Kelman tip with Centurion, and watch the arrow here, how much movement there is. Fortunately, the videos have been modified somewhat. Normally they're looking better, but there's a lot of movement inside the wound. Videos are really messed up. But you see, there's a, anyway, believe me, you never watch the incision, because you watch inside the eye, but watch your surgery and look at the tip inside the incision. This video is a little bit better. So now here, watch the incision. This is a rock hard cataract. This is a brown cataract. This is brutal. And it is emulsified, of course. It takes a bit longer. But what I want to point you at is the absence of movement of that phaco tip inside the incision. So now, as we feel very confident with the densest of cataracts. I never fear for any wound change any longer.
And you can test it directly. Just change the tip because it fits on the Centurion.
You're not supposed to tell this. So this balance tip, unfortunately, is only available on the Centurion platform. And it really gives you some balance and better quality in life. Thank you very much.
Thank you very much, Tjia. I think that's very nice coverage on the fluidics angle. Just one thing which I want to tell everyone is in 1999, we first started on the air pump system, which was, because when we started phaconet, which Alio now nicely, very good terminology given as MICS, or the microincision. That time, the problem which we were facing was we were not having enough fluid coming in. So it was simple an aquarium, and till today, then we subsequently use it for coaxial phaco. And even till today, we do the same thing of using this in all our cases. So one is to buy the Centurion, which is fantastic. Otherwise, you can simply go to any aquarium. You can just buy a fish pump, because every aquarium needs oxygen. You see, when the fishes are there, they need oxygen. And in a normal river or in a sea, you have plants which give the oxygen. In an aquarium, it's not there. So any aquarium will need an oxygen system coming in. So you can just do that, connect an IV set from there to the bottle, which pumps air into the bottle. That's a very, very good thing. And as Centurion have made it to a next level, taken it superbly.
Yeah, I use the gas infused the Accurus for FACO. Yeah, and the PC Stellars as well. And of course it provides you more infusion, but this is indeed, well, as you say, it brings to another level.
It takes it to another level.
Much higher level.
So that's what the basic things on fluidics are. I think one thing is very clear. You have to move out, as Tjia said, from the gravity forced infusion. That's definitely out. So saying that, let's move on to the next topic for discussion here, and that is on presbyopia treatment. So the question comes, how do you approach presbyopia treatment in the crystalline lens? Because today, advanced technology IOLs, and Ramon Mesa is going to talk to us on this. Today, patients are demanding. You get patients who are hyper-opaque, myopic, they don't want to wear glasses. Today, a lot of people are pumping in money from the R&D on lenses. And perhaps, Ramon, you can talk to us on that.
Okay, thank you. Before I begin, I would like to thank the General Committee of 4th Maghreb International Congress for the kind invitation to participate in this prestigious event and to have the opportunity to visit this wonderful city. I am going to try to give a brief summary of all advanced technology IOLs that nowadays we have available in the market. There are two main groups, the accommodative lenses and the pseudo-accommodative lenses. They are the most representative lenses of every group. The accommodative lenses, as you know, use the principle of refraction to create a single focal point that changes due to the accommodation with the distance of the observed object. There are simple optical lenses and flexible optics, such as ring optics, 8045 crystal lens, dual optical lenses, synchrony, Alcolens Lumina IOL. In fact, we have here Dr. Jorge Alio, one of the most experienced surgeons of this type of lens, who has participated in his design, his development. Flexible optical lenses as Nowlens and Smart IOL. Advantages of this type of lenses: 100% of the light at any distance, better MTF, less halo and glare, and they are pupil independent. But there are disadvantages: the time of the trial, increase the incidence of fibrosis, PCO, or the jet laser treatment. They achieve a poor near vision, and they are less predictable. Different sizes of capsular bag, but always with the same type, with the same size of the lens. The present future lies with the following lenses: the IOL CF, the Fleet Vision, the Dynam Curve, and the liquid lens. Within the pseudo-accommodative lenses, we are going to start with the refractive group, using the optical principle of refraction, changing the light direction to focus light at a particular point. Provide a clear vision at a single distance, and anything beyond this point will become blurred. They are the most pupil-dependent lenses within the multifocal lenses. You all remember the Rosun and the M-Flex multifocal. As advantages, good intermediate vision, especially in pupil greater than 2.5 millimeter. The option to implant in sulcus, in capsular rupture, astigmatism correction in the same procedure, and less dispersion of the light than diffractive lenses. But I think that there are more disadvantages. They are very pupil-dependent, poor near vision, especially in small pupils, the presence of halos and glare, and increased involvement with offset. A new step of the refractive lenses was the bifocal refractive lenses M+ LS 312 multifocal with a sector shape for near vision. These lenses, bioculentis, offer a the option to correct astigmatism, less presence of diffractosis phenomenon, and they are pupil independent when the pupil is between 2 and 6 millimeters diameter. Disadvantage: the small pupil, they achieve very poor near vision, and the hydrophilic material for sound syndrome. In order to improve these disadvantages, Oculentis designed, and we are able to implant since the end of 2013, a new generation of this type of lens, a new lens M+X, with additive facial severity, improvement in intermediate vision, and with the surface design optimization that provides less halos and glare, less pupil independent, and less lost light. A group between the refractive and diffractive, the Restore family, with central design, diffractive design, and the peripheral zone of the optic refractive. It's a multifocal lens, pseudoaccommodative, and apodized, and with a popular Acrisoft material. The Restore Plus 3, as you know, there are a lot of advantages: good near vision and good far vision, the option to correct the astigmatism. But as disadvantages, we can find the photosias, pupil independent, above all in patients with a bad dynamic of the pupil and intermediate vision. In order to improve these disadvantages, Alcon developed the Restore Plus 2.5 with less addition, and effectively they achieve good intermediate and good far vision and less incidence of glare and halos. But it continue being a pupil-dependent lens for near vision especially, and they worse the near vision. The third group is the diffractive lenses. As you know, the diffractive lenses use stepped rings in the optical to divide the beam of the light, creating a wavefront. When the waves are in the same phase, constructive, different focal points are provided, near point and far point mainly. Almost 20% is lost. The most representative lenses of this group are the Chris Mar Lisa. These provide a good near vision and good distant vision. We can implant through a main incision, a micro incision of 1.8 millimeter. But as disadvantages, we can find bad intermediate vision, hydrophilic material, anterior capsule contraction. There is a question of the need to implant a capsular tension ring and more incidence on PCO. The other representative lens of this type of group, the diffractive lenses, they are the Technis multifocal lenses, the Technis multifocal family. They are pupil independent but full optic diffractive design, perfect near vision, especially in the M model. They have the quality to correct the spherical and the chromatic aberration, and with a very low rate of PCO. Disadvantage of the intermediate vision. For this reason, the Abbott company developed another type of this design, the L and K design, and nowadays some surgeons opt to mix this type of lenses in order to improve any distance without compromising ni near, ni intermediate, or the far vision. Now, the current step of the diffractive is the trifocal diffractive lenses with a fine vision and AT Lisa 3. They provide a good intermediate, near, and far vision, the option, of course, to correct the astigmatism, and as its advantages, as every diffractive lens is this photopsia. Fine vision, I am one of my current lens that usually I use to implant. They offer a good intermediate, good near, and good far vision, and I think that just the only disadvantage is some pupil dependence, even with the circumvolution design in pupil with a bad dynamic pupil. The AT Lisa 3, the other representative of these trifocal diffractive lenses, offer good intermediate, good near, and good far vision, less pupil dependent, and as a disadvantage, I think that it's not the best option to implant in hyperopic patient with a small capsular bag over the time. Now, let me to show you a new design, a new concept of the lens. It's the new Technis Symphony, a new concept of advanced technology IOL. They present four main features: new optical technology for providing an extended range of vision, continuous full range of high-quality vision, reduce the incidence of this photosis phenomenon, such as halos and glare, and it's very important to underline that this lens performs with all the advantages of the multifocal lenses and those of the monofocal lens at the same time. How this lens achieve this type of advantages? There are two main features: the proprietary selected design feature, extending the range of the vision, and the proprietary achromatic technology, reducing the chromatic aberration for enhanced the contrast sensitivity. The proprietary XLS design feature introduces a novel pattern of light diffraction that elongates the focus of the eye, resulting in extended range of vision. And you know, the refractive index of the eye varies with wavelength, causing the power of the eye to be wavelength dependent. Colors that are out of focus cause blur and reduction in contrast vision. This is called chromatic aberration. Chromatic aberration can be corrected with a diffractive IOL with achromatic technology. And to conclude, I would like to present some slides common for all the multifocal lenses. The key points for me, from my point of view, we need to perform an exhaustive light examination with refractive profile. We have to perform an ideal surgery, achieving dimetropia. Of course, the results are going to improve after the second procedure, after the second eye. We have to know the premium lens market, choose the best IOL for each patient. There is no universal lens. Accept the right patient and refuse the inappropriate ones. And of course, never sell what you can achieve. Never create a unrealistic expectation. And depending on the profession, of the activities, the hobby of the patient, we will be grown if we choose diffractive for intermediate vision, refractive or accommodative for near vision, refractive bifocal refractive for pupil smaller than 2.5 millimeter, and any premium lens in extreme pupils. We are obliged to inform the patient. The premium lenses reduce dependence of glasses, but 10% more or less use it for some activities. There is a decrease in contrast sensitivity, less in accommodative lenses. Difficulty reading in low light conditions, especially in refractive diffractive lenses. Halos and glare are going to improve over time. Possibility of correcting residual refraction by optic. And of course, we can always offer an exchange for a monofocal lens. To finish, I would like to leave you with some advices from the cataract surgeon to the cornea surgeon. Always be careful with aberration with and without cycloplegic drops. Refractive errors and its ablation profile. If there isn't refractive errors and only treat the aberration treatment, the optical zone must be greater than the optical zone diameter of the lens. And in the case of pre-LASIK or intracore, only accommodative lenses must be implanted. And for the surgery, for the cataract surgery from the corneal surgery, we need a high precision biometry. We have to know corneal sphericity in order to shoot the right time. It's in the same if the previous LASIK treatment was in a myopic or hyperopic patient. To know the dominant and the non-dominant eye. After multi-zonal treatment or intracore, diffractive lenses are prohibited, only accommodative lenses. The autorefractor, of course, is unreliable after pre-LASIK, and more difficult in the pre-LASIK, it was successful. And always think about the lens area and leave a bit of cornea. That's all. Thank you for your attention.
Raman, thank you very much. I think you covered up these lenses very well, because today, let's be real, the patients are becoming very demanding, and this is not only in the Middle East, in America, in Asia, everywhere. So we have to be extra cautious, and today new companies are coming out with new lenses and they offer the moon, and which is not the reality. So we have to be very real about it. I think the next person is going to talk to us much better on managing an unhappy patient with a diffractive multifocal IOL, and Safwan Al Bayati from Dubai will be talking to us on that. Safwan is another person who is a very dear friend of mine, a person whom I've been knowing for quite some time, and I think there's no one better than him to talk to us on how he manages unhappy multifocal patients. And all my unhappy patients from now onwards, I'm going to send to you.
Thank you, Amar. Thank you very much. Good afternoon, everybody. I think that you remember, Amar, when I present 2 times this presentation in ESCRS, and there was a lot of controversy, and still we are. And definitely, I think I need to thank Ramon. He helped me a lot. He gave a lot of information related. And here we will concentrate our subject on the diffractive. And Ramon mentioned a lot of things related. So diffractive means that very sensitive to visual axis. It's when we are saying pupillary dependent, we are not meaning that when we are putting the optical zone, the central diffractive zone in the center of the pupil, the story is finished. No, it's not the truth. It's sensitive to the visual axis, and visual axis is not the center of the pupil. A second thing, contrast sensitivity, and few things, tear, film, instability, and so on. So here, this subject will concentrate about questions of a lot of doctors, that how you have, or do you have any good result from any good result, means that we don't have any good result from these lenses, or the diffractive is out of order. We don't need to use it. That's what some doctors talking to the patients. So let us start and see how we can manage. I don't have any financial disclosure with any, second slide please, with any product present here. Potentially the best in all the opinion, the best presbyopic treatment we can afford today is lens-based intraocular surgery. In spite of that, a lot of published studies done comparing the monovision to diffractive. In my opinion, that diffractive is the, sorry, it's me. The right one. Yeah, but that it's not working. Whatever. No. Yeah. Thank you. Yeah. In general, all cataract surgery, and specifically premium IOL surgery, require careful patient selection and consulting along with precise surgical technique. For that, there are several important steps that should be taken to increase postoperative success with the presbyopic intraocular lens IOL cataract surgery. Patients are divided in this study to two groups. Patient underwent surgery in our center and patient underwent surgery in other center. Patient underwent surgery in our clinic managed as follows. Pre-op parameter. Testing, I start examining the patient with tear film assessment. Schirmer test and break-up time is the guideline, the first line that I will start. Either I will continue, or that's all, I will change. And when I will change to another. So any difficulties, either I will treat and I'll try to treat, but then I will do the corneal topography. The corneal topography and aberrometry, looking to the all aberrometric changes and topographic changes. Optical biometry, OCT. Distance vision is measured here by Logmar and Snellen. Contrast sensitivity test using peropsin. And I'm looking for any changes in the peropsin that I will take into considerations. I will not depend on the OCT. Peropsin that can manage even if the patient having visual acuity of 0.4 or 0.5, whatever. It's present in all the categories of Snellen. Near vision is measured by Jaeger. The preferable near point for each patient is being assessed. The habits of near point for each patient is being assessed, and a very important point. All visual acuity measures were based on binocular vision. Evaluation. Here, it is very necessary to any refractive procedures to determine patient's daily activity and what's the patient's visual requirements are. Identify appropriate candidate for this IOL based on patient expectation for vision after the surgery. There's no perfect vision. And that's what I'm telling all my patients. Either you need to simplify it for the patient, we will lose 10% of the distance vision and 10% from the near. If accepted, we will go on. And we ask the patient to complete the form of questions. There is a questions that through which he will answer it and facilitate our work in the OPD. Patients who do not value freedom from the spectacles are not good candidates for this premium lens. Patients with unrealistic expectation for visual improvement may not be good candidate for multifocal IOL. It's important to understand the difference between the various presbyopic IOL. So I'm using trifocal, bifocal, and in multifocal +3, 2.5 accordingly, according to the need of the patient, according to what the patient's need in near. Multifocal IOL provide patients with a great opportunity of independence from spectacles, but it still has some disadvantage. Glare, halos, night vision, and overcorrection, undercorrection, IOL decentrations, contrast sensitivity issues. It's important to address the patients with these symptoms. And all my patients, they know that they will have halos that might continue to 1 year. And they might have a possibility of recentering the lens. and they might have difficulties for distance vision, all of them. And if they understand that and they accept it, then we will go ahead. And backup plan, extracting the multifocal IOL and replacing it with a monofocal IOL. And I'm showing them even movies, how we are extracting, how we are replacing, how we are recentering these lenses. Consecutive treatment and adaptation period are very important. Are success factors. Patients has to realize he or she wants to be satisfied with the vision after only one eye, and must provide a sufficient adaptation period of time. That the neural adaptation, all of us we know, that halos and night vision, it can disappear, and I didn't have any patient having night vision after 1 year. I didn't have it. Most of these night vision with a neural adaptation, it will disappear after 3 months. Few of them reach 6 months, and 1 or 2 patients of mine reach 1 year, and they have it. I wasn't disappointed. My expectation has been met. Well, that's the big issues that we need to teach the patient. They should expect all the things related to the multifocal. Prevent disappointment by providing realistic expectation. There is no golden vision in this kind of multifocality or this kind of IOLs. The golden vision that I need 6 distance, and I need the near vision that I had it before, especially for those having myo from -2 up to -4. They have a golden near vision that we will not reach it. Intraoperative parameter. Surgery were all performed under topical anesthesia by same surgeon. Clear cornea incision was performed on the steep axis of all eyes having astigmatism less than 1 diopter. Use of toric multifocal lens for patients who have astigmatism more than 1 diopter. Viscoelastic material was removed from underlying lens in all cases. Anterior capsular polisher used in all patients. Mastel device, it's a fantastic device that was used for IOL centration, which is better than Perkinj light reflex, even both having the same IOL concentration principle. And that's the Mastel. It's a keratoscope, digital keratoscope. I'm using it routinely in all those patients, definitely before I'm using Varian. Now, this movie, just click please there. Yeah, no, sorry. Again, click. Show you how I'm using the anterior capsular polisher. Well, it's important to think that this lens, we might be in need to recenter it, we might be in need to extract it. That polisher will facilitate, keep the possibility for decentration minimal. I have only one decentered after this procedure. Second movie, please. And second movie shows that the viscoelastic, I'm removing the old viscoelastic from the back of the lens to stabilize the position that the lens will be put in. Sorry for delay. Here, I'm in the back, the whole viscoelastic, and backing to the periphery, I'm removing it in a way that make sure that when I will fix the lens, there is no possibility for decentering or decentration. Third movie, the use of Mastel intraoperative. The red flickering light, see, I'm deepening the AC. And that center, here there is a light center, and the patient look at it, it's on topical anesthesia, and I'm centering the diffractive optical zone to the center of this light, definitely before using the Varian. Now, if we go to the second, next, click please. Now, when we use the Varian, definitely Varian give us a lot of benefits from the reference. I'm using this reference. That this reference show me a lot of information, taking all the registration of the eye and matching it to the intraoperative picture, overcoming all the intorsion or excyclotorsion or intorsion. See, he matched. So I don't need to mark. Here the incisions appear. Definitely I will not go to the details of the Varian. And that's here I'm doing the registration. When registration will be done, it will show here. Done. Then I will start. Now the site for paracentesis and the main incision will be easy. Now it's definitely facilitate my work. That the visual axis will be here. So it gives me the visual axis. In spite of that, I'm using Mastel just to make sure that both is coincide. Now we will see that if we will use multifocal toric, how it facilitate our work. Here, the axis, I'm rotating it to make it in, matching the axis of the Varian. Next, please. Now, that's the picture. Sorry. Shows that the alignment is misaligned here, and I will return it back to make it in the center. With the axis, here the axis also, it's out of away from the main axis that it present. Now, it's matched axis, but not in the center. Axis with the center. So it's facilitate our work, definitely. Still, I'm using topical, but it will facilitate the work for those using injection for local anesthesia and general anesthesia. Because it will give them the opportunity to target the visual axis. Now, one day post, patient first visit, patient is assessed for the centration of the central optical zone by coaxial slit lamp position by asking the patients to see through the reduced intensity bulb. The reflex of the bulb should be in the or near more than, not more than 0.5 millimeter away from the center of the central optical zone. And that's important things to make sure that we did the right things. We made the center of the optical zone to the visual or match the visual axis. One week after, we need to allow patient to ask questions, listen to the patients while we are sitting with, giving the patient the impression we are giving them all the interest to what they need, their requirement, should concern and overcome the nonverbal signs of an anxiety. Explain when improvement is expected, that if their expectation was that they will get the golden vision after, and what I have, they are expect the second day. And when I was using machines that can create a corneal edema, I will be in trouble for 1 week. Because their expectation is that they will get the golden vision next day. Explain all the options that the patient have to improve his or her vision that we might need for it, followed by visual acuity assessment, including the patient's refraction. IOL decentration management from the first to second day, I will do it, I will recentering. Residual error management, the 3rd month after the surgery. For astigmatism, I'm using limbal relaxing. For spherocylinder, PRK or LASIK. Macular edema, we are using as a preventive measure topical non-steroidal anti-inflammatory, 3 times daily pre-op, 3 days pre-op, and 7 days after post-op. In case of significant macular edema, 1 month post-op. Corneal and surface management for dry eye, artificial tear, oral nutritional supplement, the treatment of blepharitis, punctal plug, rhestasis, abnormal corneal abrasion, selective treatment for clinically significant one. Mostly it's a coma, and I'm using my machine, Tamaris, to selectively treat that coma by transepithelial PRCO or LASIK. Complication management, the capsular opacification management. Now, a lot of questions coming to me when you are doing the posterior capsular, YAG posterior capsule. The answer is YAG laser after 6 weeks of surgery, but we need to make sure 100% that the lens central optical zone is in the center or within 0.5, because it will complicate all our management later on, because we will not be able to recenter this lens. Those patients that underwent surgery from other center, they will get benefit from post-op parameter. The unfit lens, we need to extract it, and the decision for the extraction should be clearly discussed with the patient. Patients whom were informed and learned the expectation and complication showed high satisfaction and were more acceptable for any measurement we did after implanting the lens. There are many things we can do to improve visual outcome in patients with presbyopic IOL, and the unhappy presbyopic IOL patients can be converted to happy post-op patient. Thank you very much. And I'm very sorry to be long.
Thank you very much, Safwan. And I think the last topic is going to be by Mohamed Hesham Ali, and he's going to talk to us on new advances in intraoperative IOL aligning. Before I ask Hesham to talk, I think we have Francisco here, and I'd like to use your gray matter here. Francisco, you're using a lot of these multifocal lenses. So which lenses do you prefer? Anything specific which you can tell the delegates some tips on the management?
It's difficult to give an answer, Amar, because as Ramon was saying earlier, there is not one fitting all the patients. I like pretty much a restore. I like to combine the +3 with the +2.5, and I like the symphony as well.
Would you use different IOLs in different eyes, or let's say the same patient has got right eye, you have got an Alcon, and the other eye you have got an AMO, or would you like both to be the same type of lens?
Same brand.
So that's a very important message for us.
When you are using a different lens, the patient will express difference in the lightening and chromatic aberration, so that will be affect the...
So it's a very good point which you both are bringing up, and I think it's a good thing which I wanted the delegates to also understand. Thank you very much, Francisco. So we'll have now Mohamed Hesham Ali, who will talk to us on this intraoperative IOL aligning, the Verion system, because these are something which are very, very new and definitely make a huge difference to surgeons and to the patients. Mohamed.
Thank you, Dr. Amar. Just for the last question, actually I had just last week a patient who I operated for multifocal like 10 years back. It was +4, the IOL was +4, this restore at the time. And then recently, after 6 months back, I put the +3. And then he's complaining now that the new eye for the near is not as good as the old eye. So why is it? I can see this way for the smallest line. So this is actually, some people like even the +4, although we don't do it anymore. Actually, no, because he's tried this for like 10 years now. So he do like this, so, and the magnification, anyway, so we'll go back to our topic. Okay. So I will just make it as short as possible because we have to run to another session. Of course, it's very crucial that the toric IOL, which we usually do in our center, should be put in place. And why is it? Of course, we all know that it has to be put in place, but why should we put it when we are upright in upright position? Because there is always cyclotorsion, or most of the patients will have cyclotorsion, and the average is from 2 to 4 degrees on average. And it can be up to 10, actually in some studies it has to be up to 15 degrees. It can be wide range. Yeah, so it's up to 15 degrees. So that's why we have to be very careful. and we should invent something. We shouldn't depend on ourselves or our own machine or our own eyes just to measure the thing. Although some people I heard in the morning that say this is only technological bullshit. So sorry for the nonsense. So, and we know that for every degree that the lens is off, we have 3.3% loss of the astigmatic effect or astigmatic correction of this lens. And if we have 30 degree off, because this is 3.3 by 30, we will lose all the astigmatic correction effect of this lens. And if we know that in the hour, 1 minute is 6 degrees. So it means that these 6 degrees will make us lose 20% of the IOL correction. So this is how important it is to put the lens just in the right axis without any shift either way. So what we used to do is to do the 3 steps corneal marking. The first step is put the patient upright and mark it either with the air bubble markers just to see the horizontal and vertical meridian. And then intraoperatively we do the Mendes ring and put the corneal marker on the proper or the calculated IOL axis. And there has been some study by Versa et al. In 2011 said that the first step, the mean error was 2.4% plus or minus 0.8. And the second step is when we put the vertical, the patient upright position. And the second step, when we put the Mendes ring on the axis that we marked as the horizontal one, there are possibility of average of 3.3% error. And in the third step, when we mark the cornea for the required position of the lens, the possibility is 2.6. So if we add all this, it will be like 8 point something % of the axis that we want. So there have been some methods came up just to let us not be dependent mostly on our eyes or our hands, like Dr. Robert Ocher, who just thought about the iris fingerprinting. He said that the iris has fingerprints, and if we see these marks, so we can know the vertical and horizontal axis, and then if we mark this one, it's most probably intraoperatively we put the lens in the proper position. But when we dilate the pupil, and when the cornea gets hydrated, sometimes this fingerprinting is not that obvious. So there came another thing, which is the intraoperative wavefront aberrometry from the Orange company. And this machine just makes real-time intraoperative wavefront. There are, this is the company, this is the introduction, actually I got it from the internet. So this machine has a light that goes inside the eye, and then it's reflected back, and then splitted. The light is splitted, one to the microscope, and the other one to another device that goes through a double grid. Sorry, can I go back? I made something wrong. Yeah. Anyway, so it goes back to double grid filters, and these double grid filters will go to a computer that will make the wavefront, and you will see through the microscope the actual refraction of this patient intraoperatively. So, and if you put the lens, you can see that there are residual astigmatism, and I think it can even tell you to rotate the lens 10 degrees this way or 1 degree this way, and even the power of the lens is measured intraoperatively. So sometimes, especially in the post-LASIK or post-refractive surgery, the proper IOL calculation is not that easy. So even then, it can, and in children, it can tell you if this lens is the proper lens for the patient or no. And then I have a very short experience with Varian. This is a real-time, and Dr. Safwan, of course, talked about it. It's a real-time eye tracking based on iris blood vessels, the conjunctival blood vessels. And the platform is designed to avoid the multitude of the errors that can occur along the entire pathway from the initial patient to evaluate the execution of the surgical plan. It allows the surgeon to deliver the more accurate refractive results and a higher patient satisfaction with greater consistency. There are two units. It measures the eye and image the anterior segment and perform the IOL calculation. This is the thing that you put it in the outpatient. And then there are the second one that will guide the surgeon intraoperatively to put his incisions and the centration that Dr. Safwan just explained. So I'll just skip some of these slides. The data can be integrated from this machine to the Lansix, if you're using the Lansix, to the microscope. And this interface, the good thing about it is you can put it on any microscope. Any microscope can do with this interface. So if you had Muller, like one we have Zeiss, another one. So we put it on the Muller because the retina guy didn't want it to put on the Zeiss because he's using it. So this is a surgery that I've done. I just done it last Monday. Can you make it on, please? Can you put it on? Can you click it? Yeah. So this is a patient that had PKP from Dr. Anwar. Actually, no, sorry, it's the DLK from Dr. Anwar because Dr. Anwar doesn't do PKP. So, and we removed the sutures. She had astigmatism like 4.5 degree. There's lots of astigmatism. And she's a young girl, about 25. She has posterior subcapsular cataract, most probably from the steroid. So what we've done is we removed the sutures, waited until the stability of the astigmatism, and then just made the variant. And I was amazed because this is maybe my second case of the variant. I will not go through the surgery because all of it, but the thing is, the capsulexis here is very good actually if you can put the actual size of the capsulexis. If you put it, this one is 4.8. Yeah, you can select this 4.8, and the centration of the capsulexis, even if the eye is moving, and this is topical anesthesia, so even the eye is moving, so you can track the capsulexis. So maybe it will just take some of the patients from the Lansix, and then we put T9 patients for these patients, restore T9, and postoperatively, second day. I saw her last Tuesday, and her vision was 20/20. So, and I was amazed. Post-PKP, large astigmatism, I wouldn't have achieved this kind of results with my normal one. So it looks, this is the future, and this is not nonsense. This is the future, and it will stay here. And I think it will be mandatory for every toric patient to have this kind of either machine, because we have lots of companies that have coming up with this thing, but we'll have it, the manual one, because this is my second case. If you see that I put actually corneal markers just to be safe. Yeah, but usually now we don't have to put any corneal marker because you're confident about this lens. I'll just keep the rest of the surgery. Yeah, because even when you're irrigating or putting the second instrument, there are torsion by your hand, so it's super fast. And thank you very much for coming. And
thank you very much, Mohamed, and I'd like to thank each of you for coming here for this session here. We'll have a break now and then wait for the next session to start. Thank you very much.
Up in